This is Selma Schimmel for the Group Room at the ESMO 2012 Congress happening now in Vienna. We are joined by Dr. Eduardo Vilar from the University of Texas MD Anderson Cancer Center. Hello, Dr. Vilar.
Hello, how are you?
The genomics of cancer and personalized medicine really is quite a highlight for us at this ESMO meeting. So what were the highlights of your talk?
As you know, I am working in MD Anderson in the Department of Clinical Cancer Prevention, and I have had a long-standing interest in hereditary cancer, mainly hereditary colorectal cancer syndromes. As the audience know and the general public knows, the proportion of people that develop cancer on a hereditary basis is around 3 to 5% of the total of people diagnosed with cancer, which is a relatively small proportion, but it's a critical proportion because these patients are a higher risk to develop cancer during their lifetime. So we are trying to learn better ways to prevent this population to develop cancer. And one of the things that we are learning right now is that we can develop targeted chemoprevention strategies to prevent the development of cancer, and later, if unfortunately patients or families affected by these diseases develop cancer, we can also identify targets that may lead to have better therapeutic approaches and treat those in a more personalized way.
Dr. Vilar, could you explain a little bit about the role of tissue collection, analysis, and molecular pathology?
That's essential. I mean, I think in the moment that we are right now, we are experiencing a shift towards a more personalized care, and this is precisely what we need to do. We need to inform the public better in the way that we need to collect prospectively the tissues in all our patients, have the highest quality of tissue, and being able to do massive genomic analysis so we can gather all the information that we need to better tailor what are our interventions in terms of care. I mean, we should be able to make better decisions in terms of prognosis to inform better our patients, and then also to learn better what is the biology behind the disease and tailor treatment. So there are many initiatives, and particularly MD Anderson is being a pioneer in this work with the Institute of Personalized Medicine, Personalized Treatment, where this is precisely what it is doing.
In the area of colorectal cancer, do you have challenges that we know in lung cancer, just getting enough tissue is a problem? What about in colorectal cancer? Are there challenges there?
Well, there are always challenges in all tumor subtypes. Fortunately for colon cancer, we can access the primary tumor through colonoscopy. That's a great asset that we have. Although it's an invasive technique, it's something that is very well tolerated. So we can access the primary tumor without not having too much trouble and get a collection of that. In terms of metastatic disease, there are always challenges. As you know, the liver is the organ that gets metastasis more frequently in colon cancer, as well lung. So always getting a fresh biopsy is challenging, and we should be doing a better job informing our patients sometimes of the critical need of doing that if that is the case, to access tissue.
What are some of the pathways that your research has revealed in the area of colon cancer?
Well, we have been working on the classical pathways. So one of the advantages of colon cancer is that it has been molecularly defined and subtyped since very early on in development of molecular biology. There is very well understood, two pathways that are very well understood. One is the one that is going through the APC Wnt pathway, and the other one is the mismatch repair pathway. Precisely yesterday during my talk, I was talking about the work that we have been doing in my lab during my postdoctoral fellowship, and now in the University of Texas in MD Anderson, trying to identify new chemoprevention strategies and new targeted therapies for Lynch syndrome and MSI tumors. So in this regard, the essential pathway for us is the mismatch repair pathway, which is very interesting. I mean, the deficiency in mismatch repair introduces a lot of genomic instability. The tumor accumulates a lot of errors.
Are there current examples where you can talk about a particular therapy that aligns to a genetic or biologic understanding of colon cancer?
We have solidified knowledge with the use of two standard chemotherapy agents that are currently used in the treatment of colon cancer. We know that patients that have microsatellite instability, mismatch repair deficiency, should not be treated in stage 2 with a classical chemotherapy drug that is called 5-FU, because through many studies, retrospective analysis, have been shown that 5-FU does not have any benefit in patients that has microsatellite instability of mismatch repair deficiency. We are still currently working on other preclinical studies trying to develop new target therapies, and that's what I am doing in the lab and what I have been published. There is currently research, clinical research on the field, but we don't have anything solidified that is approved. It's everything right now on the grounds of clinical research.
Is there a familial association for patients and colorectal cancer?
2 to 3% of the total of patients that develop colorectal cancer will develop that on a genetic hereditary basis. So that means that there is a genetic defect that is going to be carried on to the next generation. There are particularly 2 types of syndromes that will predispose the population to have genetic syndromes. One is what we will call the polyp maker type syndrome, where patients grow many polyps, literally hundreds to thousands of polyps in the GI tract. That is very well understood and known. It's called familial adenomatous polyposis, FAP. We know that these people have a very high risk and will develop colon cancer, certainly. So these patients will beneficiate of an early referral to genetic counseling because they're risk-reducing surgeries and therapeutic interventions that are needed. And then let me explain you the second type, which is the mismatch repair germline mutation, or also known as Lynch syndrome, also known as hereditary non-polyposis colorectal cancer. In this type, the patients that have a germline mutation in the mismatch repair genes do not grow many polyps as the polyp maker type. They grow several polyps here and there, but we know that they are at an increased risk to develop colon cancer, and in females, endometrial cancer, which is also very frequent in this syndrome.
How do you screen if you know you're at greater risk based on family history?
The job starts looking at the family tree, the genealogic tree of the family, identifying what are the individuals that has been diagnosed with what type of tumors at what ages have been diagnosed. So what is the profile? And by looking at that, we make the determination if this is a polyp maker syndrome or it's not polyp maker syndrome, so we can reorient one thing to the other. And then we basically try to do genetic analysis on individuals that has been already affected to start with. Then if we get a positive result, we expand the analysis through the rest of the family members. And this is just a genetic testing, which literally is drawing blood and extract DNA. This is for the case of FAP, of familial adenomatous polyposis. But for mismatch repair and Lynch syndrome, the other things that can be done as initial screening is to look at the tumor and do molecular analysis in the tumor, test the tumor to see if there is microsatellite instability. If that is determined, then we move to genetic testing in the case of Lynch syndrome. Then you talk about the screening. What can we offer these patients? We offer to these families? We can offer them to have an intensified screening. As you know, in general population, we recommend to have a first colonoscopy at the age of 50. These people probably are going to beneficiate to start the screening with colonoscopies at a younger age. And that's something that has to be individualized case by case and family by family, depending on when has been diagnosed. And then the frequency of the colonoscopies is something that has to be tailored.
What should the viewer who's just been diagnosed with colon cancer, hasn't started treatment yet, what do they need to know?
They need to know, and I like to, when I am talking with my patients in the clinic, I like patients that are well informed. I mean, I like people that Nowadays, I mean, we have internet, and there is a wealth of data. Obviously, we have to be very selective with data. So what I will tell the patient is that they have to rely on good sources on internet to get the information. So they have to be picky in that way. But I like patients well-informed, patients that are coming to the clinic because information, it's empowering people to better understand what's going on. I think that the time where the physician is offering a menu to the patient, it's over. So it has to be a dialogue between the physician and the patient. So a better informed public it's able to understand what are the challenges. And also, I think information for the patient is key because you are going to build a strong relation with the patient, is going to be very well informed, and is going to be more receptive to be involved in clinical research. And that's exactly what we need in oncology. We need a motivated patient that is willing to help himself and help the future generations in getting involved in clinical research that made us advance the field. One of the things that I stress in my presentation yesterday is that both the community of patients and the community of physicians has to be more receptive to involve patients with cancer diagnosed on a genetic background in clinical research, in clinical trials. They are going to provide an invaluable information. It's not only, I mean, it is not only that we are beneficiating clinical research, it's care for our patients. These patients have a genetic defect, and the biology of the disease is controlled the majority of the time by that genetic defect. So I think they are probably going to beneficiate a lot on having targeted therapies and targeted interventions and being involved in clinical research and clinical trials.
You are practicing, researching, and in your professional life, living through a really exciting time. So I'll look forward to meeting with you again at a future meeting to find out what progress you're making and what you've learned next on the molecular and biologic front on cancer, hereditary cancers, and personalized medicine.
Thank you so much. It will be my pleasure to be back here to tell you about our research findings and our progress in fighting cancer.
Thank you. Dr. Eduardo Vilar from the University of Texas MD Anderson Cancer Center.
Thank you so much.